ALIF, anterior lumbar interbody fusion. What does that mean? The anterior means we go in from the front, lumbar means low back, interbody means we take out the disc and fuse the two vertebral bodies. We get the bone to grow between the bodies through the disc space to stop the motion. And then fusion means we get the two bones to grow together, to literally fuse together. So what are reasons to do the ALIF approach? One is if you're suffering in back pain and have any neurologic pinching in the nerves. In general, if your pain is around an 8 out of 10 and you failed conservative management, doing the surgery can get you down to around a 3 out of 10. So if you're really suffering from pain, the surgery may really help you. The reason to do the anterior approach is because it gives us great access to the disc space. You can literally see the disc like this, which allows us to take out the disc, put in big spacers to correct deformity, and get a high fusion rate because we got a lot of bone and a big spacer in there with a lot of stability. The way the surgery is done is we go in from the front, we don't cut any muscle. So minimally invasive surgery basically means save the muscles. So we go in between the rectus muscle, we don't go through your stomach, we actually go around the side, either the right or the left. All your organs are in a sac called the peritoneum. We actually go around that sac, we don't go through it. Then we come down on the spine. You have blood vessels that sit on the front of your spine, your aorta and your inferior vena cava. They branch to go down to your legs. L5S1 is typically the easiest one to get to and safest because the blood vessels split above it. We go right in the middle of the split. L4, 5, and 3, 4 require more mobilization of the blood vessels out of the way to get to the disc. So there are risk of complications to those blood vessels. We typically use a vascular surgeon who does the approach and moves those out of the way and puts retractors in to give us the exposure to the disc. Then we take out the disc, get all the soft tissue out, get all the cartilage out. All of that blocks bone growth. And this gives us the best view and access to be able to get it all out. Then we put a spacer in. And the spacers, this is a plastic spacer where it's bigger in the front and smaller in the back. They're wedge-shaped, usually 6, 12, 18 degrees. And we put in the spacer that fits each individual person the best to open up the front to get the lordosis back. We did a paper that proved that doing the ALIF, the anterior approach, gets lordosis, this height back, better than any of the other approaches. And the reason why is because you cut the big ligament in the front, get great access, and jack it back open. And so it's very effective for that. We typically do ALIFs at L5S1, the bottom one, because it's the safest one to get to, and because your pelvis blocks going in from the side, which is the lateral or the XLIF or DLIF. If somebody has a big slip at L4, 5 with a lot of deformity, we may do an ALIF there to correct the deformity as well. The results of the surgery, like I said, are typically from around an 8 to a 3. If you're at an 8 out of 10, the surgery may get you to a 3 out of 10, which is good results. A 3 out of 10 is worth noting that some people would be at a 1, some people would be at a 5. 3 is the average. So a lot of people still have pain and stiffness after the surgery, but typically they're a lot better than where they were. Recovery from the surgery, we typically get people up and walking immediately after the surgery. Most people stay in the hospital for about 1 or 2 nights, sometimes 3 nights. They're able to drive typically around 2 weeks after the surgery. We typically start physical therapy around 8 to 10 weeks after the surgery, and then it's progression through the rehab program and how far out are you from the surgery, are you having any symptoms, and how do your x-rays look determines return to activities. Typical return to activities is about 3 to 6 months, and it may take up to a year for the bone growth to become completely solid and return to almost all the typical activities. The other type of surgery we do with the ALIF is we have 2 options. We either go from the front, put the spacer in, and put 2 screws up and 2 screws down to lock it in place, or we put the spacer in the front and then put in pedicle screws in the back. This surgery from the front is less invasive because we never go in the back. But these screws in the front are not nearly as big as the pedicle screws in the back because they go all the way across the axis of rotation. So this is less invasive, but it's not as strong, and it may even take longer for the bone to grow because there's not as much stability. If we go from the front and the back and put the big screws in the back, it provides more stability. The fusion may occur faster. And we're actually able to put these screws in from a very minimally invasive approach with this computer-guided 3D system. We've used it for over 15 years, thousands of screws put in with it, and allows us to make small incisions off to the side that spare the muscles and preserve all the muscle and blood supply to the other levels. So there's two different techniques for doing ALIFs. There's even more than that, but those are the two general ones. They're both very effective surgeries, and we really determine what's best for each individual person to make that choice. You have two choices at this point. You can either email us at info@watkinsspine.com, or if you want to come see us in person, please call 310-448-7890. Thank you.